we then look at a number of other adjustments that we can make. And so we're looking at a couple of different types of adjustments to make in this context. One is to apply a risk adjustment, and so this is largely, if not entirely, based on diagnosis codes captured from the claims. And we actually look not just within the episode, but we look for quite a period upstream of the episode. I think it's over 365 days prior to the procedure. We look back that far for any diagnosis codes on any claim that would indicate a higher risk of complications. And where we see that, then we're applying a risk adjustment. So in a sense, the treating provider is being held against a commendable level or an acceptable level, or being held against a higher cost threshold. We're also considering making an adjustment for select cases that are admitted through the ED. In the footnote, you'll see listed here 4 presenting conditions for patients coming in through the ED. Chest pain is the example that our clinical advisors have brought to our attention, where a patient is brought in with chest pain. They're admitted to the hospital out of concern for cardiac issues. They're cleared from the cardiac exam, and then it's determined that they have gallbladder disease, and they're recommended for a cholecystectomy. So in those instances, we want to make sure that the provider is not being held accountable for those extraordinary costs of the patient having come in through the ED and having been admitted to the hospital. That provider may have just presented with the patient for gallbladder disease. They may have likely done the procedure on an outpatient basis. And so we're thinking about how can we make an adjustment to those costs so that provider is not in the calculation of their performance, that they're not being held accountable for the costs of that inpatient admission. We also want to look at, after we calculate the average cost for any given provider, we're going to provide reports to providers regardless of how many cases they have within a 12-month period. However, a provider would only be eligible for gain sharing or only subject to the risk sharing if they had at least 5 cases. And this is just so that we can kind of reduce the probability that within any one period that one case could really kind of swing you into the red or into the green zones.
This is Fayetteville.
Just a couple other points, and then I'll pause for feedback. On the quality metrics, Dr. Golden had introduced that we always want to have a number of quality metrics, at least one quality metric which needs where a minimum standard needs to be met in order for a provider to participate in gain sharing. And so here it's proposed that metric would be cholecystectomies with ultrasound performed prior to the procedure. And then we would also be, for reporting purposes only, tracking and reporting back to surgeons the rate of major complications that occur in the episode. The goal is, right now, we're looking for feedback so we can get the episode definitions right, so we can get the analysis as to be as meaningful as it can be with all the exclusions, and then that's the next step is for us to produce these report cards and publish those, and both to make people aware so they can start to change practice. And we also expect that we're going to get further feedback from folks at that point, and both Blue Cross and Medicaid are both quite open to making further adjustments to the episode definitions and inclusions and exclusions, even after that point that those report cards are provided. So no, the 180 surgeons have not yet received it yet because we don't yet have kind of episode definition. Until we go through this process, we're not comfortable that we've got it right, that we want to put out data that would indicate who's in the red and who's in the green, so to speak. But that is the intention to get there quite shortly. On the CT scan, so let me just kind of describe the principle and then seek your advice. So I think the principle is we want for, in this case, Medicaid has determined that the principal accountable provider should be the general surgeon. And so the goal is that in the future, we want for that general surgeon to kind of be the captain of the team, the quarterback, so to speak, and to take accountability for that full episode. And that would include communicating back with primary care physicians who may be ordering procedures which are helpful, unhelpful, or failing to order procedures. We want for them to be the quarterback of that team and to take a very patient-centered kind of longitudinal view. We recognize that doesn't entirely happen today. We recognize that the general surgeon in this case may not have information, complete information into that entire episode, and so that is the goal, to provide that information. I think that so I think we would be looking to capture if an ultrasound had been ordered, whether the general surgeon had ordered it, a primary care physician, or anyone had ordered it. And I guess I would look for guidance from you on it. In that case, if a CT scan is satisfactory, and if it would be wasteful to then do an ultrasound, then I think we could just consider kind of coding it so that a CT scan would qualify. I don't know if there'd be any downside to us doing that.
Well, I guess the devil's in the details for this whole situation, and that's just one of the details. And there needs to be a mechanism.
My guess is what we'd probably do with that. I'm just thinking again. This is again formative process because it's not finalized. It would be some percentage of your cases. If 50% of your cases were diagnosed by CT scan, probably would not be a great idea. But if a certain number get done by a CT scan, I can understand that. Right. But I don't think that should be the predominant. So I'm not sure. You would have to adjust the metric. I wouldn't expect 100% of your cases to be ultrasound diagnosed. I think
there would be probably a perfectly natural tension here, right? That we'd have a quality standard for ultrasound, and we could count a CT scan as well towards meeting that quality standard. As you said, it's for the majority of surgeons, it's going to be kind of well in excess of 90%. And so the purpose of the quality standard really is to just surface outlier cases where, if you had a surgeon whose cases, let's say, were only 50%, or 60% were having an ultrasound or a CT scan, that would be of concern, it sounds like. And so we wouldn't want to be paying out gain-sharing payments in those cases. And then, against the possibility of overuse of CT scans, I'm not sure that we expect to see that. But if we saw that, the episode design would be a barrier to that, right? If you're being rewarded for the total cost of the episode, and if you had a lot of CT scans, you're going to have trouble qualifying for gain sharing payments. So I think that we can make an appropriate allowance for it. I think we have Seth. We have another question or comment.
Are you trying to say that you want a certain standard, certain percentage of people diagnosed with biliary disease by ultrasound only?
I think we would like feedback from the physician community regarding what would be a minimum quality standard that we should establish
by ultrasound.
And this was the proposal that we came up with from interviews with a number of general surgeons, that a minimum percentage of cholecystectomies the patients should have been diagnosed by ultrasound, or perhaps we would also count if it was.
I agree with him. There is a much larger, I think, than 10% of biliary disease diagnosed by CT. It's just abdominal pain workup by ER, primary care physician, whatnot. But then you've also got things like HIDA scans, gallbladder ejection fraction things that you need to consider as well. Now, most of those people will already have ultrasounds,
right?
Too, but those are going to be negative ultrasounds. So
obviously, most people would think. Correct me if I'm wrong. Most people would consider on a routine evaluation, the ultrasound is usually your first test. Now, granted, there are folks who do abdominal pain shotguns, but if you're suspecting a gallstone, you usually start with an ultrasound. Isn't that correct?
But I tell you, the way that those patients present to the emergency room is with abdominal pain, and they get a CT scan. As the insurers know better than anyone, anybody that comes into the emergency room with abdominal pain, they're going to get a CT scan.
And you've got to consider, too, in the emergency room, in our hospital especially, in a lot of hospitals, they don't have ultrasonography at all hours of the night. So the CT is going to be the primary mode of them diagnosing this. I would estimate easily of my gallbladders that I take out from the ER, more than 50% easily are from CT.
Okay. Those are not tests you ordered. They're being ordered by someone else.
Someone else.
And that's almost always the case.
Sure.
The referrals that come to my clinic are sent from primary care docs that, by and large, have already ordered an ultrasound. The referrals that come out of the emergency room are almost always come with a CT. The point that I think, gosh, it just seems to me that that we can come up with a better quality. If we've only got really one quality metric for game sharing, is this the best we can do?
Right.
And it just seems to me that we can put our heads together and figure out a better quality metric that'll have a bigger bang for the buck than getting whether they got an ultrasound or not.
Are any of you working with the American College of Surgeons database or the VA database? I was just curious if they have any metrics with this kind of thing.
I've worked with it I've worked with it in the past, and I'm pretty familiar with it. I don't know that they don't have something like correlating the number of ultrasounds or the ultrasound to the procedure.
Right. Well, at a minimum, this is exactly the feedback that we're looking for. At a minimum, what I'm hearing is that we should count ultrasound, CT scan, et cetera. We should expect that it should be a very high number, and that if we saw any general surgeon for whom a significant number of cases had neither a CT scan nor an ultrasound, that there's probably an issue. But I hear you saying that you just don't expect to see. You don't expect to see much kind of variance from 100% on this one. I think we would welcome if there's other suggestions of metrics that are more meaningful. We do have in mind to measure and report the frequency of major complications. I think the concern with using that as a performance metric for gain sharing is it's a low frequency performance metric. So somebody who for Medicaid does 20 cases and for Blue Cross does 30 cases, just kind of statistical variation within any 12-month period. Someone could have average performance over 5 years, but in 1 year they could have negative performance. And maybe that's okay. Maybe we're saying, well, in that 1 year, we're not going to say whether it was random or not. They're just not going to get gain sharing. We're not penalizing anyone for it. We're just saying you're not going to get gain sharing if you have within 1 year, abnormally high rate of complications.
The problem is the complication rates. It's a low-frequency event.
Yeah.
So it's hard to use that as a measure.
Totally.
On the other hand, conversion rates or percentage of open cases, getting rid of the, that has some potential, but it's actually built into your cost, your average cost per case.